Okay. Hello, I'm Dr. Sana Zainab, one of the FY2 doctors in the emergency department. Can you confirm your full name and age for me, please?
My name is John Garrison, and I'm 70 years old.
Okay, so John, can you tell me your son's full name and age?
My son's name is Marty Garrison, and he's 21 years old.
Okay, all right. So what brought you to the emergency department today, James?
My son had a seizure, so I brought him in immediately.
Okay, so sad. So can you please make me go through what happened, and can you tell me more about the seizure?
Okay, we were watching football when he suddenly began shaking violently and fell on the ground. The seizure lasted approximately 2 minutes.
Okay. Okay, all right. So, was he just sitting idle on the when this seizure happened, or was he doing something?
No, like I said, we were watching football together.
Okay, all right. So, before the seizure, was there any complaint of headache or vomiting?
No,
Okay. So, all of a sudden, he had a seizure, and there was nothing happened before that. No symptoms reported.
before the seizure, he was a bit sensitive to light and sound recently. He's been complaining about being too sensitive to light and sound.
Okay. So, has he complained about like this before, or has he had a seizure like this before?
No,
This was the first seizure in his life.
yes.
Okay, all right. So can you tell me what were the symptoms during the seizure? Did he lose control of his bowels or bladder?
Uh, like I said, he was violently jacking. And then shortly after the seizure, he started behaving strangely.
Okay, so did he
And
lose
he
consciousness?
seems confused.
Okay, okay. Did he lose his consciousness during the seizure?
Yes, he did.
Okay, for how many minutes did it happen?
Just for a few minutes,
Okay, and then he
like two
regained his
minutes.
consciousness.
Yes.
Okay, so did he bite his tongue during the seizure attack?
No,
Okay. So, was there episodes of vomiting or headache after the seizure?
no vomiting.
Okay. After this seizure, were there any other episodes of seizure while you were in the ambulance or when you came to the hospital?
No, he didn't have any other episode before we came to the hospital.
Okay. So, okay, all right. So, does he have any other medical conditions?
No,
Okay. Is there any history of seizures in his other siblings or your family?
no,
Okay. Any previous surgeries undergone on him?
no, he has never undergone surgery before.
All right. Is he allergic to anything?
No, no issue of allergies, no allergy to anything.
Okay. Is he taking any sort of medications? Any
No, he's not on
over-the-counter pills or anything?
he's not on any medication.
Okay, all right. And any travel history recently?
No,
Okay. So does he work or is he a student?
pardon, please.
Does he work for a living or is he a student?
He's a student, he's still a student.
Okay, all right, perfect. So I also want to know about his general habits. So can you tell me, does he smoke or drink?
No, he doesn't smoke. He does not. Occasionally, he drinks alcohol.
Okay, and what about his dietary habits?
He's been normal diet.
Okay, all right. Uh, so James, I have to do some examination of your son. That will include his vitals examination, his fever, blood pressure, and heart rate or respiratory rate, etc. And I will also do some examination of his, especially neck, to see if there is any neck stiffness. And also, I would like to do examination of his cranial nerves. That involves, I want to see if there's something wrong with his brain or if anything's wrong there. So should I proceed?
Yes, you can.
Okay. All right, so I have undergone all the examinations and his according and investigations. And according to his investigations reports and all the history that you have given me till now, um, I'm suspecting that he's suffering from a viral infection caused by a virus known as herpes simplex virus, and that has affected a part of his brain that is leading to seizures. Um,
Okay.
okay, would you like me to explain further about the treatment?
2 minutes remaining.
Yes, please go ahead.
Okay, so it is a virus. This is known as herpes simplex virus that due to this viral infection, there is the infection has happened in his part of his brain that is leading to seizures. So as it is a viral infection, we'll surely treat this with antiviral medications. Okay, we'll have to put him on acyclovir, which is an antiviral medication for 7 days, and we will also keep him admitted because it is an IV medication, we will give the medication through his veins. So we'll have to keep him admitted and also to observe that if he gets another seizure during this time or not, and if his condition worsens or not. Is that all right?
Yes, it's okay.
Okay. And meanwhile, I will also guide you about some serious things that if you notice that he's vomiting persistently or he complains of headache or if his confusion worsens, then you have to contact somebody from the emergency department immediately. All right.
Okay.
Meanwhile, we'll keep him admitted and we'll also check his other vitals continue with the monitor, and we will also provide him symptomatic management as he is also suffering from fever. So we will also give him paracetamol to cool down his fever. Okay. Also, okay.
Thank you.
Then we'll just observe the effect of the antiviral medications, and if we'll have to change any medication, then we'll do while he's staying in the hospital. All right.
Yes.
Any other concerns that you might have?
Actually, I'm emotionally really bothered about my
Um,
child's condition. I'm very worried and
um,
anxious about his
Move on to the
condition
next station.
and how it will.
All right, guys, good job. All right, yes, this was viral encephalitis caused by HSV. So when you say viral encephalitis, what is affected? What is the one? What is the infection of? What is it an infection of?
I said infection of the part of brain.
All right, or you can just say brain because it's encephalitis, right? I mean, part of brain. Know from the MRI that it's temporal hyperintense in intensity, hyperintensity, sorry, having a brain fart. All right. What else could it be? Right. What is the other close association that you would want to rule out? Or how did you
Um, we should rule out meningitis, types of meningitis.
Good job. Good job. And how did you manage to rule out meningitis?
I went to the examinations and then I just got all the details of our tests and investigations.
Absolutely. So basically the neck stiffness bit, so you have.
Yes, I told him I'll examine the for neck stiffness.
So the meningeal examinations is known as the Kernick sign and Brudzinski sign. So in Kernick sign, what happens is if you flex the knee, in the neck also flexes on its own. And in Brudzinski sign, on a flexed hip, if you try to extend the knee, you won't be able to. All right. So these are a couple of the meningeal signs which are very classic for any irritation on the meninges. Right? So this is one way to. How did you manage to say it was viral, Dr. Sana?
Due to HSV, herpes simplex virus.
All right,
Um,
that's good. So one thing that I want to tell you that encephalitis, especially viral encephalitis, one of the most common cause is HSV virus, which in the first 72 hours it might not be positive on PCR. So there is always a repeat test that is usually done. All right. So in the first 72 hours, it might not be positive. I just want to put it out there so that you guys know about this encephalitis type. But what is the other thing that you would see to check it's viral? Anybody? Anybody can give
CSF analysis showing normal glucose and elevated lymphocytes.
Absolutely, that's good job. So in case of bacterial, bacteria needs to take on the glucose to survive. So the glucose will be low, and usually it's neutrophilic. So neutrophils are the first response of responders, right? So yes, those were correct. No visible rash. That's also something that you want to rule out for any bacterial meningitis, any meningococcal meningitis especially. There was fever. So how did you manage to differentiate it from epilepsy? What are the questions you will ask to differentiate it from epilepsy?
Because it was a first seizure, and we never say it's epilepsy just on the basis of one seizure. It has to be 2 or 3, I think, with like this, and unprovoked with no other infection or any underlying cause.
I think I'll have to disagree there. I mean, the epilepsy also has, has to come with a seizure, right? I know to make it a diagnosis of epilepsy is difficult, but you have to do a whole lot of tests like EEG and all to rule it out. Fever, that's what. How would you call it an infection? Epilepsy is not an infection. It's the, inactive firing of the brain neurons, right? But in this case, that is happening because of an underlying infection. So you have to think about the markers of infection. So since you've got infection positive, that's why it's less likely to be epilepsy. All right. So let's quickly just review the case. So in this case, appears to be caused by a virus called the herpes simplex virus. This condition can lead to symptoms. So, how severe do you think? Why would you admit this patient? Like you mentioned that we'll admit this patient because the medication that we're giving is IV. But, would you admit this patient other than the medication being IV?
No, because he's having fever, he's having confusion, and that can also worsen. So we need to observe him for if another seizure occurs or if his condition or confusion worsens.
Absolutely, that's absolutely correct. In these are, especially when there is an infection of the brain, you have to be very careful. He is having some post-ictal effects, he is confused. He can't recollect what has happened during that seizure time. Those are signs that he needs to be monitored, right? And he needs to get prophylactic medications for seizures as well. So whenever you're thinking of encephalitis, you're thinking of it not going into the meninges. So some of the times it can also present as meningoencephalitis. So that way you can't actually differentiate it between the meningitis, the classic meningitis that you know. It's actually a very difficult diagnosis, to actually have a presentation in the clinic and find out what it is. Sometimes you'll actually get positive meningeal signs if the meninges are involved. So most of the times in these cases, you actually give, empirical antibiotics until, bacterial meningitis is not ruled out. So you're already starting them. You have to immediately start them on acyclovir without delay. And then you have to give them a bacterial cover as well, until you actually get the CSF, get the culture, and then find out there is no bacteria at all. Because bacterial encephalitis will be far worse consequences, and you really don't want to go through that. So you have to give them a bacterial cover as well. And then seizure management, you have to give prophylaxis for seizure. If he's still seizing, then lorazepam. Otherwise, you have to give prophylaxis in the form of levetiracetam or phenytoin, right? Intracranial pressures, these are all the sequelae of encephalitis. They have a high ICP. So you have to make sure to give maintenance for the ICP itself. Elevation of the bed, maintain normovoluminia, avoid hypotonic fluids, right? Consider mannitol or hypotonic saline if herniation is imminent. Right? What happens if there is so much of intracranial pressure? You know, the brain might actually herniate out of the foramen magnum. So that would be a far worse consequences. So you understand this case is such an emergency that so many life-threatening complications can occur. So you cannot send this patient home at all. So giving IV and antiviral is one of the causes, but there are far worse causes due to which you have to admit him, monitor him. You have to continuously take their GCS, check their levels of electrolytes. So this also comes with another added, issue of SIADH. So you have to keep checking the what you say sodium in these patients to make sure the patient hasn't gone into SIADH, right? So this is a very emergency case which needs admission. In fact, you will admit the patient and also be arranging an ICU or HDU bed because it's that much of a emergency. And then frequent monitoring, monitor for complications, investigate further. So lumbar puncture or imaging if no improvement or diagnostic uncertainty. Repeat, CSF, HSV, PCR after 48 to 72 hours if the initial result is negative. Most of the times the initial result also comes negative for the HSV. So in the Canada information, I gave it positive one, but even I'm telling you for a clinical setting, even if it does come negative, you have to repeat it. Mostly after 72 hours only does it come actually positive. Follow-up MRI. So another thing about this case is that most of the times the presentation of this case would be with a high, opening pressure. Opening pressure is the pressure with which, when you do an LP, the pressure that is with which the CSF comes out. That's called the opening pressure. Usually it's around 10 to 20 mm of H2O. If it's more than 25, then it's, herniation imminent. Right, it's like a high ICP. So you really want to maintain that. So when it's a high ICP, you never do an, this one, what to say, an LP. This could cause herniation itself. It will cause rapid flow of the CSF out and it can cause herniation of the brainstem. So what do you do for that? You check the pupils to check if there is any papilloedema or anything, any signs of, high opening pressure or GCS vitals pupils to actually check if there is high ICP at all. Other important things, so as soon as you identify that this is an encephalitis case, you have to involve the infectious disease and the neurology referral. Get them on board as soon as possible because this is a very difficult diagnosis to handle. You need specialist advice. Apart from that, you have to also inform your senior that there is a case of encephalitis that has come in. Also, because it's also a notifiable disease. So there are so many things to this encephalitis case, apart from just admitting them. Admitting them is the mainstay. You cannot send them home. You have to make sure they are admitted for the complications, for the treatment, for the monitoring, for so many different reasons, right? After you got them in, make sure that you have intimated all the seniors and the responsible specialities, along with getting an ICU bed. So all these things need to be set in motion one after the other. You admit them, administer IV antiviral. Apart from that, also give a bacterial cover. Along with that, you have to make sure that if they are seizing, you have to give them lorazepam. If not, then you have to give like a prophylactic to prevent any further seizures, right? And then apart from that, you have to make sure you inform every responsible unit, the infectious disease, the neurology, also the ICU. Make sure there is a bed reserved so that if this case gets complicated, you can shift them immediately, So there are a lot of things that go hand in hand when it comes to such an emergency case. And along with that, you have to make sure that they don't deteriorate. You have continuous monitoring. So you will be writing in the chart how often to monitor this patient. So you're doing GCS, Q2H, meaning every 2 hours check the GCS, and then, electrolytes, how often to check the electrolytes, Q8H, to see that they haven't gone into SIADH. And the urine output, because SIADH can also be monitored by the urine output. If they're putting out more urine, if it's, hyperosmolar in this case. Yeah. So yeah, that was that was encephalitis, and encephalitis is one interesting case because it can be confused with meningitis as well, right? But what are the history that you're taking? Usually, the age of the person is very predictive. Around this 25, 28 years old, they do have this chance of getting encephalitis with HSV. Apart from that, if it's a notifiable disease, so would you actually do the contact tracing in this case? Would you want to, like in meningitis, you try doing contact tracing and you find out who were in close contact? Would you do that in this case? It's a notifiable disease also. Anybody? It's okay, there are no wrong answers. Let's just give it a try. It is not contagious. Yes, it's true. It's not that contagious. So you do not do contact tracing in this case. You don't need to give prophylaxis. That's correct. Yes, let's quickly look at the performance. All right, confirm the full name, age, identity relationship of the accompanying person, elaborate on the presenting complaint, ask for detailed history before, during, after. I think you were getting a little repetitive over here because Dr. Amuko actually mentioned in the beginning itself that, he did have, after history actually mentioned that he was a little confused and he kind of, he wasn't the same. His behavior was a little different from, what it used to be. So there was a little repetition of questioning over there. So try to gauge it the first time, the patient is mentioning it, right? Otherwise you get marked for listening. Apart from that, you asked a lot of good history of what was the before history. Was he complaining of any, headache? He said he was complaining of some shyness to light. And another classic history, especially for HSV in this case, he might be having some slight flu-like symptoms before, right? So that is also something that you can ask. Another risk factor that you have to, ask for is any tick infections. So these are also something that can be borne by insect bites, right? And another history to ask is the immunization status. Like, was he fully immunized as a child? Right, because measles, mumps, rubella, they all present as complications, as encephalitis. So that is another good question to ask. Like, was he immunized as a child, fully immunized as a child? All right. Elaborate presenting complaint, detailed history of the past, including any epilepsy, diabetes, immunocompromise. That's a very good question. And medication history. Explore social, occupational history, living arrangements, lifestyle stressors, alcohol, drug use. Yeah, you need to think about any injectables, that he could be using, that could be causing any encephalitis. Check for vitals, general physical examination, neurological examination, other relevant examination. Acknowledge and validate, acknowledge the relative's emotion, explain the need to gather detailed information before making decisions, emotions. Inquire about systemic symptoms like fever, photophobia, neck stiffness, rash, recent viral illness, and to rule out meningitis or encephalitis. Ask about any travel history, outdoor activity, tick bites to rule out vector-borne encephalitis. Ask about neurological symptoms like memory loss, personality change, confusion, or hallucination. Rule out head injury, substance use, or recent ingestion of unknown substances. Ask about recent viral illness or contact with any sick individuals. Absolutely. Yeah, I guess data gathering checks out. Management, explain diagnosis, likely viral encephalitis, but you never really explain what encephalitis is, like what does it affect, So you can just say that this is a kind of infection that affects the tissues of the brain, the brain tissues. So it basically affects the brain parenchyma, but yeah. And a very classic finding of HSP is the temporal lobe involvement. There is always that's why I specifically added that. I went a little overboard with the investigations, but these are very classic findings where there is hyperintensity of the temporal lobe. And EEG, this is when it's actually when the person is seizing, then you will be getting this EEG, by the way. I just want to put it out there. I thought, that's something I can explain, but I can take it out after this, because EEG, it'll come as seizure when the person is actively seizing. So just keep that in mind. Apart from that, you have start acyclovir empirically immediately. Explain the importance of early and antiviral therapy, monitor for complications like seizures, SIADH, herniation. Yeah, seizure was something that you covered. Add ceftriaxone empirically if bacterial meningitis or meningoencephalitis cannot be ruled out at this moment. If the patient is actively seizing, administer lorazepam promptly and loading dose of anti-epileptics like levetiracetam. Assess for and manage race ICP. This is very important when it comes to encephalitis. It's literally the inflammation of the brain. You are going to most probably find race ICP. You should think along those lines that there is going to be race ICP in these cases. Do not perform lumbar puncture if signs of raised ICP. So when you can't do this, you have to do brain imaging instead of the ICP, and you have to find ways to reduce the intracranial pressure, right? So when do you actually think along those lines is when you get an intracranial pressure, that pressure itself, even you get a papilloedema finding or something like that, then go in for imaging instead of ICP, lumbar puncture. But these things will not be it won't get tested. They just want to know what are the investigations related to encephalitis, so they'll just expect you to say LP and imaging and stuff like that. But I'm just telling you for your knowledge. Yes, Dr. Sana, you have something to say.
Yes, I wanted to ask that can we just rule out raised intracranial pressure based on the history, or do we have to do the pupil part compulsory?
But how will you rule out the raised intracranial pressure with history? Like how
That with vomiting and headache, persistent vomiting.
I agree that could be one of the signs, but it does not necessarily have to be because of the raised intracranial pressure, right? So the only way to definitively know if it's raised intracranial pressure is to do a fundoscopy, right? Because vomiting can be due to a lot of different reasons, right? Even though if it's persistent, it's indicative of a raised ICP, even a headache also. But you can't say for sure that it is happening because of a raised ICP. You can't defer LP because of that. No, because LP over here is diagnostic. You need to understand whether it's viral or bacterial. That's the first thing you're thinking. Even imaging cannot differentiate that. You can only, and you have to do a bacterial, and you also have to do a CSF culture, right? So the only way of doing that is by doing an LP. But you just, when you're thinking of encephalitis, you do not want to cause herniation. That's why you're ruling out papilloedema or any raised intracranial pressure before doing LP. This is, I'm talking for a clinical setting. They might not go into such details in PLAB 2, but just keep that in mind when a patient comes with encephalitis. Raised intracranial pressure is one of the biggest complications, and do not do an LP around those times. You look for ways to reduce the pressure, and then you do an LP. Just wanted to put it out there. You still have a question, Dr. Sana?
Yes, another question is that the investigations which you gave, there was clearly written that it's PCR strains for HSV.
Yeah, I know. I went a little overboard with the investigations because I just want to make it very sure that this was SSV. I mean, I wanted to put that as investigation. I wanted to explain it a little further in the class.
Yes. So initially, I was just trying to crack down the CSF report that what it might be. Is it TB meningitis or what? And then I just thought that there is HSV written right in front of there. So will we get the investigation results like this in the exam to crack the CSF report?
You most probably you might be getting, but in PLAB2 most of the times they will actually be writing what the CSF report means. You know, like if it's a complicated report, they actually say, or most of the time whenever they give value, they keep the normal values on the side. But sometimes they may not. So it's good to actually know how to interpret them. Right. So CSF report, if there is glucose, always look at the glucose. When the glucose is low, then you're thinking bacterial, right? Otherwise, you're actually thinking